clinic area. So if you use a code card, please let somebody know, usually on nights, and if it's really crazy busy, security can do it, respiratory sometimes will do it. A nurse does not have to go down and get it. They don't have to be clinical, okay? But you need to replace it, and all you have to do is put the Zoll on it. If you do give it to somebody that is not clinical, and really just get in the habit of putting it on all, there is a code card lock that I'll show you in just a little bit that you need to lock it up, just to make sure things are safe, all right? So on the very top is IV meds. The carts are set up exactly the same. It used to be alphabetical, but for those of you that have that drilled in your head for years, that's no longer the case. They reset them up so that they look very similar to what they have in Roanoke, since we have so many travelers and people that are coming up from Roanoke. So I'm going to kind of pass this around. Just keep in mind there's plenty of epi for those who have ACLS, because that's the main drug we use. But there's two concentrations, and we'll talk about that in a bit. But I'm going to pass this around just so you can see. So speaking of epi, the 1 to 10,000 is the old version. That's the 0.1 milligram per cc. That's in the Averjets, okay? IV bolus push. There is also a vial on the very top on the left that is epinephrine 1 milligram per cc. So it's a different concentration. That is only to be used for iron injections, like for anaphylaxis, or to mix an epinephrine infusion. Do not use the Averjets for an infusion, okay? And if you do so, there is a sticker that you can put on the outside of the bag, all right? I think that's about it. Oh, actually, I saw this. Pharmacy made up a little anaphylaxis kit down in the very bottom left hand. So there's the high concentration epi, the 1 milligram per cc, just the cc of it, with a syringe, needles, filter needles, because it's in an ampule, okay? So that's where an IM injection takes place of an EpiPen in case of an allergic reaction. I just talked to the pharmacy. There's only one dose on that. So if you have to give a repeat dose, she's going to get back to me on that. For now, if for some reason, before we find out from pharmacy what they're going to do about that, don't forget you do have the 1 milligram per cc vial that you can access. Okay? Does that make sense to everybody?
Is that an ampule that's in the
kit?
The kit?
Yeah.
Make sure you use a filter.
There is a
There's one
filter
in there.
needle in that kit. It's ready to go. Yep. All right. So, let me get rid of this. This goes under the patient backboard. On the ones upstairs, you don't have to push this down. You don't have to unlock it. All right, so top drawer, IV supplies, syringes, needles, IV start kit, so if you have to start from get-go, they don't have an IV, all that kind of stuff is in here. Second drawer, IV fluids and tubing. This is where the dextrose for the epi drip and the more epi is here, okay, 250s. There are a few pre-mixed meds. There's lidocaine, there's dopamine, there's amiodarone, and there's nitroglycerin. So those are you that may not be familiar with giving nitro. We don't use it that much anymore. But anything in a glass bottle has to be vented, right? Or you'll get a vacuum and it won't run. So our tubing has a thing that you flip open that opens the vent. So if you're not sure where that is, just ask somebody that has worked here for a while, and they can show you how to do that. Third drawer. This is so super full of stuff. I swear, people swear they cannot find this stuff. So all I can tell you is I'm going to open this and let you all look through it. but we're gonna set up a cart. When we're gonna do some practice scenarios throughout the year. Me and Diane's gonna do it on day shift. I'm gonna come on night shift, and we'll let you dig through stuff. But there is everything all the way from nasal cannula, non-rebreather, right? Suction equipment. There's ABG kits, end-tidal CO2, oral pharyngeal, nasopharyngeal, ET tubes, both handles and blades, but we are going disposable. Have we started doing that already?
Some of the crash cuts have it, this one will have it.
Okay. So everything you need for your airway should be here. One of the things that I discussed with somebody most recently was they could not find this during the recent rapid response. This is the end-tidal CO2 adapter you have to use with the Zols. And they couldn't find it. People get in here and start throwing it, and then you can't find stuff. All right, so if you're not sure, ask somebody that might be familiar with the carts. But please don't start digging. This is a viral filter. If you're gonna bag anybody or put them on anything that's gonna expel air, they need to have a viral filter. BiPAP, CPAP, and do that kind of thing. Protect the staff in the room.
Do they routinely put lubricant in there?
Yes.
Is that something that came up?
It's right here.
Long time ago.
It's right here.
Thank you.
Yeah, I swear, see, that's why we want you all to look through the cards when you come around. Because, I mean, we don't have that many codes. Sometimes we have 3 in a day. We were just talking about that, but we can go months without one, and people forget where stuff is, okay? Bottom drawer is really just all sizes of bamboo bags. So we have infant and child in case you're waiting for the Broslo cart to arrive for a while. There's also some PPE stuff in there, and saline and sterile water bottles. All right, over here are our extra Zols pads. We have a child one too, once again, in case you're waiting for the Broslo to arrive. You should already have an adult pad already attached, right? That's how we do our functionality. All right, middle drawer. We have both sterile and non-sterile gloves, electrodes. So if they're not on telly and they have no electrodes, this is where you find them. In order to connect them to the monitor, we have a 3-lead system here. And even if they're on telly, I would just go ahead and leave that on and put new leads. Okay. It gets really busy on their chest. There's only 3 leads. Bottom, blood pressure cuff. There is a stethoscope. There's a flashlight, and then this is the ECC book that we use. Down in Roanoke, they use laminated cards with the algorithms. We chose to stay with this because we've been using it for years. And it actually has a lot of information in it. There's all the algorithms, meds, you can look up stuff that aren't maybe on the algorithm, like antidotes, that kind of stuff. Just keep in mind that red is ACLS, okay? And then purple, I'm gonna pass out because I'm breathing in this fast, excuse me. Purple is pass.
Take it out. I dare ya.
Yeah. We practice. I learned my lesson in December. I already told you that. All right. There is suction, oxygen. It runs on batteries for a while. So you could roll it outside if you have to and run a code. If you are in a patient's room, please plug it in because you don't want the battery running out in the middle of the code, okay? So let's talk a little bit more about the Zoll. Here is your monitor. I don't have it attached to a patient. So when we come around and do our mega codes, we will actually have a rhythm that will show up here, okay? So the rhythm will show up here. You have the capability of doing a blood pressure, there's blood pressure name. You can do a SpO2, so you can do a pulse ox right here. You don't have to run and go find equipment. This is the end-tidal CO2. And I have an end-tidal CO2 guru right here. She loves end-tidal CO2. She should use it. There really is no reason why you shouldn't have this on a patient. It's on all the Zols. We have the capability of doing them on our GE monitors too. But this is where you need the adapter I was talking to you. So this gives you end-tidal CO2, a better indication of your oxygenation. And if you're coding them, it also tells you if you're getting lost. So it's kind of important to put that on. Respiratory is supposed to remember, but they sometimes don't. So please remember that, okay? This will give you CPR quality. So if you're using our Zoll pads, anterior, posterior in general is the best way to get all the functionality. You will lose that CPR quality if you don't use that. Unfortunately, if you're going to use the Lucas, that's not the best way to put the pads because the Lucas device goes right on the pads and it'll tear them up. Not to mention you're not going to get good CPR quality coming. So you gotta maybe use up here and here, okay, just so you don't have to keep changing pads. And Diane will talk a little bit more about that. Let's see. Any questions? All right, so that's enough on me.
Okay, the Lucas, and this is hands-on, so can you guys, if you're gonna be using the Lucas, come up? Rise.
Before we start that, the green tag I was talking about, this is kept in the same drawer as the extra Zoll pads. This is what you need to lock up the code card if it's been used, okay, before it goes back down. Sorry about that.
So this device has proven to save lives. One of the studies that was done on this, there was a gentleman that was hypothermic and he was in full cardiac arrest, and they used this for 8.5 hours on him and got him back. Because in hypothermic cardiac arrest, you're not dead until you're warm and dead.
Yeah.
So a few things about this. One, it weighs 26.5 pounds. Ask me how I know. Been lugging it around for a couple of days. It will, you don't have to unzip this. It has this little area right here where you can plug it directly in and charge it. So you don't have to unzip to feed it through, and you just charge it. Okay? A battery will last about 45 minutes in use while it's being used, and there is another one that can be used if you run a code longer than 45 minutes.
What are they doing for that hour? I guess just swapping out the battery?
Yeah. And I can tell you, I was in Danville, and we had to take a lady by ground because she was in full arrest. And they put their extra battery on the outside of their truck. So we had to stop on the side of the road to get the battery in. Yeah. Always keep that battery available.
I was thinking, with that thing on for 8 hours, he probably wanted to die afterwards. He was like, please.
Well, the lady that was a hypothermic arrest that I did, she actually, we got her back. She couldn't make it after that.
Yeah.
This you have to put on the back of the patient, okay? Because what it does is this will click into place. So this is Lieutenant Dan, because he ain't got no arms and legs. Thank you. Last group just like, huh?
Some of us are old enough to know.
Exactly.
Were they babies? I didn't know.
So who wants to help me?
I'll help you.
All right. So we're going to lift the patient up.
Well, should we roll the patient?
We can.
Yeah.
But we're going to, for purposes of ease, we're going to lift him. Okay. But
All
otherwise,
right.
you can roll and shoot it right
Yeah.
under there.
There you go.
Now this actually works better if you have two people using it. So what you want to do is you want to pull it out. The battery's already in it, and you want to grab right there. You have to lift this yellow lever, lift it, and then hook it into place. You hear it hook? Did yours hook?
Yeah.
All right. So, and then you're going to bring this down, and what you want to do is you want to have it above the xiphoid process. And one of the things people will do is they'll actually mark it, because if a person is sweaty, wet, or anything, it can slide around actually. So you'll do that. So then what we're going to do from that point on is we're going to go on and start CPR. There's a couple of options of CPR. One is continuous, and one is the 30 to 2. Okay? So you're going to hit this button and turn it on. And it's showing you have a full battery. You put it down and it's sealed into place. See, it's above the xiphoid. And then you've got these buttons. So you're going to want to do, let's do 30 to 2 to show what that means. So you'll hit that and it starts. So after 30 seconds, you'll hear like ding, 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 and then they'll want you to give the 2 breaths. And then everybody's hands are free from this now. Okay?
2 breaths.
Giving you 2 breaths, and then it automatically starts back up. So, now, the nice thing about this is where you will have to stop this and pause it with that pause button in order to do a rhythm check. Okay, so you do your rhythm check. Once you finish the rhythm check, and it says, let's say it says shock advised, you can start it back up, And it can actually do CPR while you're defibrillating. Whereas you can't do that with humans. You still want to call all clear to make sure that nobody gets shot, but then you've got this one. Now, continuous literally means it never will stop. So the person that's in the airway will have to kind of synchronize it. Stops it. So let's say that, you'll pause it.
Yes, ma'am.
So, don't have to scream. Let's say Lieutenant Dan does have arms. We can take this strap here, put it behind his head, and what you'll do is there's these here, his arms will go back this way. You click this into place, kind of pull it to snug, and then these arms are like this. Most commonly what you'll see done is this. They'll put them up here. If you would let me have your arm, please. You'll never get loose. And then it's free and out of the way. Okay? Since I like you, I'll let you. All right. Any questions?
Yes.
Battery. Where's the extra battery?
The extra battery is in
How do
ICU.
you change the battery?
The extra battery is in ICU, and you're going to.
Where in ICU?
Yeah.
On the shelf where we keep our monitor from transport.
Oh, yeah, where the Lucas is.
Nice
I would never be able to do that again. So what you do, you lift up under here, and it pops out of place. You will have to, you'll have to turn it back on.
Okay.
Or actually it turns on, and you'll have to put.
How do you charge just that battery? Like if you're
It's
switching
a
it out?
holder, and up in there. It's on this shelf, literally right above this. So, and then this stays charged because it stays plugged in all the time. The disadvantage is you cannot use that CPR monitor thing because of this. So let's say that we get the patient back, we stop CPR, and get the patient back, so you're going to lift up out of the way. And what are you going to replace? The only thing you got to replace is this plunger, which literally just pops right off. Put a new one on. And then if you do use this, then this is supposed to get replaced.
Okay.
Where's the other plunger to replace it?
It should be in ICU. It's not here. I think it's in the purchase. Oh, okay. I thought there were spare ones up there.
Black file cabinet
Yeah.
where the
Oh,
mask
yeah,
are.
where the
Okay.
Yep. Any questions?
And if you use the last one, please let me know.
Yeah, so
So
she
that
will.
I can get more.
But seeing that on an actual person looks completely different than seeing
Yes,
it on
and it's weird.
It
Oh,
looks-
yeah. Mhm.
It
It
looks
will, you
vicious.
will hear ribs crack, you will hear
Yeah.
ribs pop.
It looks awful.
But you know what, better alive in a sternum fracture than dead in a sternum fracture.
That's true. That's very true.
I've been in a couple of situations where the patient was larger and it was
Right.
very difficult to get the other side to click. You get one and
True,
the other side
in
wouldn't
very
click.
large patients,
And there was a
you-
delay in CPR.
well, you can't, actually, they suggest you not to do it in really large ones, because these two filters
Yeah.
right here cannot be blocked.
Right.
Because what it'll do is it'll heat up this mechanism and it will.
And you should be
They'll
on
burn
that
it up.
chest while they're getting the Lucas prepped. I mean,
Mhm.
you should be doing
Yeah.
compressions.
Yeah, and one of the things, if you guys want like some Con Ed or continuing education, is you go on Physio's website and do the Lucas 3, there's a test, and you get a certificate afterwards, and then you can upload the Cornerstone for that also.
Real small people.
Real small people, it won't work either.
Mhm.
So, we little ones and real big people.
So I have a problem that we detected when we were doing our checks one evening. Somebody who had used it or checked it, I can't imagine just it being checked, I think it must have been used. Put it back wrong, and it was backwards and it was not charging.
Yeah, yeah.
Was not a staff member on the patient. I'm surprised, not surprised.
Okay, so if you look, you see that hole?
Hold a hole.
Hole to hole, essentially. So, yeah.
So if you don't see the lights and you check it, it's not in there.
Yeah, yeah, it'll show a green light on top that it is charging.
Okay.
Okay? Ding dong. Any questions? Next is difficult airway bag.
Yeah, that's somebody else.
This is just kind of. You can sit down. So, let's say that the whoever's, like, does RT intubate here?
Usually, don't.
Let's say the ED doc is having trouble doing standard intubation. This is, not only does it have a surgical crike, but it also has blind airway devices. They are kind of barbaric. They are sized, so pay attention. These go by height, and pay attention to what it says on there as far as how much you inflate it in regards to the size of it, because not all are the same. It also has some LMAs and some various EP tubes. So a couple of things you'll see. If you have, let's say you're in ICU, you can't get the patient intubated, and they do need a surgical crike, and anesthesia's not here, worst case scenario, it's night shift, anesthesia's not here, and you know you're gonna fly this patient out. Lifeguard can do surgical crikes, okay? They will bring their own stuff. They will not use this, I can assure you. They got rid of those about 5 years ago.
Okay.
Because there was a problem with, once you make the vertical cut and then separate it, there was a problem getting to go through the membrane, and it was actually rolling up. So what they went to was a blade, a bougie, and an ET tube, which is a shortened ET tube, so that it's not like flopping all over the place. Has the same premises. Now, I will tell you, I did 2 in my career, and they are bloody. So be prepared for that, that they are not, it's pretty scary looking. So you may see blood spurt out of the person. And then they've got a secure airway, because it'll inflate the balloon, and that'll have a secure airway. Excuse me. But they'll bring their own stuff. You don't have to pull this out. But this would be for the physician. Now, I don't know how often your physicians practice surgical crikes, but I do know the lifeguard does it every quarter. Every 3 months they have to do these. So. Any questions? Okay. And this is beside essentially the Lucas. So blind insertion devices and advanced insertion device. Okay? All right, last thing, Janine is gonna talk about code documentation. So that's an area that we need to improve
Hey, I
on.
have a question. Did we ever come up with a, like, is there a backup bag? Is
No.
the bag just in
No.
isolation?
No.
Okay.
No,
That was Elva's patient.
Yep.
The COVID room.
Yeah.
Easy as, a wall, you got time to look, they got all their stuff on, in the code room. And, they have that. And, if anesthesia comes in, they got stuff over there and,
So, are we supposed to take, wipe everything off?
Excuse me.
Put it in, when we wipe the bag off?
yeah,
Okay.
just wipe it all down, that's all Susan did. Just wipe your bag down, wipe the stuff off on the inside of it, and then she replaced the stuff.
Okay.
You're gonna use that.
Sorry, shut me off.
Is the RQI thing still in that extra room where we did the,
Yes.
y'all ready?
No, it's right.
It's in the small conference room on the
third floor. Go down the hallway. There's a sign.
See the other side.
Okay.
It's right next to the,
Nursing room, mother's room.
It's a yellow sign right outside the door. It's RQI.
All right.
You will ventilate.
Quick, thing that we didn't mention. Does everybody know how to call code?
Hit your button.
Code blue button if you got it. They'll call it overhead, help will arrive, right? Rapid responses, you cannot hit a button. That
You
has-
can if that's all you got.
Yeah, if you're stuck in a patient's room and that's all you got, you'll get help.
Yeah.
You can always send people back, don't hesitate to call them. Rapid, you have to overhead page, and there's the medical alert thing, so you have to say medical alert, rapid response, where you are, that kind of thing. But that has to be overhead page, okay? So if you're not sure how the phones work, please ask somebody that's been here forever.
well,
It's
on the
page
new
all.
phones,
No,
on the new
black
phones,
ones do not have it.
there is no page all 600. A few weeks ago, Amy and I were talking about it, and we went through each button to just figure out which
Somebody
one.
labeled the one. in
That
the
was me, because I didn't know which one it was.
Everyone has a certain amount of OCD, right?
It was me.
And you're right, the black ones do not have that. Yes, very good. All right, so unfortunately, I cannot resize this picture to show you all the things, so we might have to have a little group meeting around the screen to show you the whole thing. But I can show you the basics on this, okay? So, all I can say about,
Someone wants to know what number to call over again.
Excuse me, 600.
did you all get this? Okay. So I just recommend putting it in your locker, your mailbox,
So
whatever.
it still is like 600?
No, that doesn't take you
They're going
anywhere.
a different way,
You
right?
have to use the speed dial button. Yeah, I'm sorry, I didn't say that.
So,
That's why I labeled it.
So the older
It's only on
version
one phone,
phones that
though.
are black or gray have a page all 600 button, because that's what we use to dial. But that dialing 600 will take you nowhere. So you have to use the speed dial button. So find out if you have a black phone only, you gotta get that labeled, like ready.
There's only one that I labeled in ICU. Sorry, y'all have to figure it out yourself.
Because that would be our phones.
we'll get it figured out on the search, I will label.
So documentation for both codes and rapid responses. All I can say is unless you do them a lot, you are never gonna be able to do them in real time. They are not user-friendly. They're very, very busy. The screens have numerous links. I just recommend making sure somebody is writing down stuff. Don't rely on a dry erase board. In the ICU, we've been writing it on the doors, and that's helpful. But have somebody writing down time, what you're doing, that kind of thing, because you're gonna have to go back and document. Okay?
Don't we still have the sheets on the?
Yes, thank you for mentioning that. So on the clipboards of all the code parts, there are downtime forms for codes. People forget they're here. So you could use this for your cheat sheet on documentation. There's nothing wrong with that. It has all the meds, the rhythms, if you're shocking, if you're doing CPR, that kind of thing. So don't forget they're here.
And when you don't have paper towels or
Yeah.
to writing on a piece of paper, and I'm like, time we get, time we get, time we get.
But I can't emphasize it enough, I know it's a pain, especially if you've had a busy night or busy day and you're ready to go home, you have got to sit down for half an hour maybe and document your code or rapid. Don't leave it for somebody else, that's your responsibility. And there have been issues where appropriate documentation has saved this facility from legal issues, so please document. So, speaking of documentation, I'm going to show you kind of what it looks like on the screen, but I'm going to have to go over here to show you all the specifics. I can't get the screen to get to the right magnification. So here in the patient's chart, on your main page, there should be a code documentation tab, okay? Then you choose down here code blue or rapid, so either or, okay? So if it's a code blue, you click on it here, and then you will come over to here, and here are a bunch of links. So here, under code start and stop, hit code start. So when you click this button, it automatically starts the time, and it'll be documented. Over here, you can put the time also, and then start your procedure, okay? So documentation, vitals if you got them, interventions, that includes CPR, defibrillation, intubation, bagging, that kind of thing. You can do several interventions all in one screen, okay? Cardiac rhythm, I cannot emphasize enough, please don't forget to do that. I do code and rapid response reviews, and that's the main thing I cannot find the nurses forget to put what rhythm they're in. Usually I can find it somewhere else, either in the documentation, in the actual narrative notes somewhere. But don't forget to hit that, so all you gotta do is hit that, and it won't let me do it because I didn't start it. It'll give you a list of all the rhythms that they could be in. Quick notes is just you can actually do a blank note, and the ED does this a lot, where they put the time, what they're doing, and that's their like little cheat sheet. And then it's in Epic already. So I'll leave that up to you, whether or not you want to do that. You know, as long as
Easier to translate it from that sheet right into a note.
as long as you can see it, that's fine. But we were talking about OCD. ICU nurses are notorious for it. I don't mind going back and documenting it correctly. So I'll leave that up to you to decide. Please don't forget to add your staff. It will be preloaded with our staff. I'm not going to go here because it shows you all kinds of weird stuff. But all the docs that we have here, all the nurses we have here, the respiratory therapists we have here, the aides we have here, that kind of thing. So add the staff that's in the room. Here is some of the meds that they might already have and the lines they may already have, okay? If you end up putting or giving them meds, they'll be over here. Every med that you might give is not here. So if they write an order for a med, it will show up on the flow sheet, okay? So if you can't find it, have the doc write an order. Here's if you intubate, you hit ET tube, any kind of reversal if they're obtunded. There's anaphylaxis, IV drips. So here you got your drips. IVs if you have to start an IV. Tubes if you have to put an NG tube. Or catheter, that kind of thing. It's all there, it's just a lot of links.
Yeah.
So there's just no way.
Yeah, it's impossible to do it in real time.
Right. So if you are going back and doing it later, you have got to change the time of that intervention every single time. And it will not take more than one thing unless you go in under intervention where there's several things under the same time. So say, for example, at 4:30, you did a bunch of things. If it's not under intervention, you're gonna have to put 4:31 or whatever. It won't let you use the same. All right. So, I am going to go over to here now, because I cannot show you what it looks like. So if you all feel like you can come around here, might be cool. I'm gonna show you what they look like. Sorry. All right. So this gentleman coded on us, and this is what it looks like if you document, okay? So you have your code start. I put my rhythm down, intervention. So we started compressions and we defibrillated because he was in VFib, all right? So then we resumed compressions after we shocked him. And then we gave him 1 milligram of epi. So here's all your times, okay? So this is just the ACLS protocol, and this is how I can tell when I'm doing reviews if they're following the protocol, by looking at this kind of stuff. So what rhythm were they in? VFib. The epi didn't work, so we ended up giving 300 of amiodarone, right? Resume compressions, that kind of thing. And then they came back into PEA, right? So we resumed compression, gave him another dose of epi, and we got vital signs back. We got ROSC, so they came back in sinus rhythm. We ended up intubating them. We ended the code, and they stayed in the ICU. If they were on med surgeon, they got transferred to the ICU under outcome over here. See where you can put where, if they didn't make it.
Yeah.
Family was notified, chaplain was notified, or if they were transferred to high level of care, went to OR, or they remained in ICU, that kind of stuff, all right? So I can show you a little bit more, because I've already opened a code, what these things look like. So the documentation. Interventions has a bunch of stuff. So you have compressions, you have defibrillation, you have, if you cardiovert them, it has pulses present, if they have an airway, if you're bagging them, that kind of thing. So there's it's all one stop for a few things. All right. Don't use this up here, the quick bar, unless you're doing it in live time. You cannot change the time on that. That's really reserved for if you're doing it actually during the code. And like I said, it takes people doing it routinely to get that down. There's a few people in the ED, they like to park here. They like to be, because they know how to do it. But, all right, let's see what else. I think I'm gonna go all this. Does anybody have any questions? So let me show you what a rapid looks like. All right, so this is the rapid. The rapid response is much more user-friendly. Almost everything is all on the same page. So you started a rapid, and you hit the big box for rapid, come over here under rapid, and hit start, right? So then it'll ask you a bunch of things. Don't put end yet, because you don't know when it's going to end, but you can always go back and enter that time. So it'll ask you for what it started, what caused it, respiratory arrest, altered mental status, that kind of thing. hypotension, there's selections. What rhythm they're in, don't forget to put that, all right? Staff that are there, that kind of thing. So it's all, this is what it looks like when you finish putting it all in one thing. And then when you end it, all right? Just don't forget to write a note also in the progress notes. It does not need to be 5 paragraphs over every little thing that happened to the patient that day. Just a brief progress note on what happened. Patient found in respiratory distress, O2 sat 80%, put on a non-rebreather, rapid response called, see flow sheet, something like that. Because that triggers me to look at it if you did not do a flow sheet. I get, if you do a flow sheet, I get them automatically. But it also clarifies what went with the patient. All right. Does anybody have any questions? All I can say is keep those little papers in your cubby or whatever, because I guarantee you're gonna have to pull it out and look at it. Because it's just so onerous. There's so much documentation. Great. Okay, that's all I got.